Just getting everything set up and waiting for 9.
So, perfect. I don't know what I do exactly. Looking to the upward now.
All right. So what you got? Thanks for joining me, you two. So I was able to figure out how to stream this live to Facebook directly to our Facebook group. But I'm still trying to iron out the kinks, so please bear with me.
Hey, what's up, Al?
All right. So I'm just getting everything set up.
Can you hear?
All right. Thanks for coming, guys. So we're doing a just a Zoom meeting to talk endometriosis and just kind of an open discussion and talk some surgery and I don't know, just get some you know, try to fill up the days for maybe some of those who you know, like this COVID thing is kind of crazy, so I kind of wanted to take up some of the time of those people who are really bored and I don't know, feeling kind of isolated with this whole thing. You know, like a lot of us have families and kids and you know, have our weekends filled, but you know, I know that there's some people out there who you know, go to work on the weekdays and come home to an empty house or empty condo or apartment. And, you know, I was thinking like maybe like this whole social distancing thing is a lot tougher on some of us than others. So I was thinking maybe to try to put out some Zoom meetings just to kind of keep everybody a little bit sane. We're almost through this whole thing, but I don't know, just trying to keep everybody's mind occupied. So that was the whole point of why I wanted to do this. And it's the point of why I wanted to do it on a Sunday when normally it's like a family day. So I figured if there's any day that's hard, it's going to be this one. So thank you guys for joining me. I appreciate it. So I wanted to talk about endo, and I had a short, well, not so short, but just a video that I wanted to show. And if you guys have any questions or anything, maybe we can do it through the chat box. Because if I put the video on, it's gonna kind of make a loop of sound. All right. So anyways, let me see if I can get this video going. Hang on a sec, guys. I was trying to make sure this would go smooth. Let's see. I'm gonna hook up this video now, and we're gonna start watching. And I guess we can just kind of talk as we go through, and I'll talk about like the case details.
Can you hear us, Al? Can you hear us?
Hold on, Steve. Oh. I can hear you.
Okay. Okay.
Yeah, I got you.
All right.
All right, let me find this video.
Be careful.
All right. Let's see. All right, you guys see that?
Yeah.
Okay. So this is a case that I had. How's that coming out? Okay, Steve? Hold on.
Yeah,
let me-
we can see it. It's a little delayed and
let me try again. Hang on a sec.
speeds off a little bit.
All right, this will make things better. Hang on. How's that? Better?
Yeah.
All right. Thanks. So this was a case that I had, I guess maybe a couple months ago. So it's a 37-year-old female who, who came in through the ER. So she had a previous surgery, I think 2 months prior. She came into the ER for pelvic pain, and her pain evolved. It was cyclic, and then it became persistent. And in August, she went to the ER and ended up undergoing a laparoscopic left drainage of a endometrioma. So I guess the surgeon, took her to surgery, did a laparoscopy, stuck a needle in this large left adnexal mass, and aspirated, chocolate-colored fluid, and apparently excised some endometriosis and left. So after the surgery, she did nothing. She had zero. She had zero improvement in her pain. And 2 months later, she came to see me, still complaining of the same exact pain. So, I guess even before August, she was tried on birth control pills, and I think she got Lupron before also, like a year's worth of Lupron, and of course nothing touched her. Did ultrasound, and the ultrasound showed a complex fluid-filled left adnexal mass, and she also had a simple appearing cyst on the right ovary. So I put my scope in, and I find this large dilated left fallopian tube. She doesn't have never been pregnant, wants to have kids, but she doesn't have a boyfriend or a partner. So of course I'm going to try to do everything I can to maintain her fertility. But the fact that she already had a previous surgery just 2 months prior, she wanted for me to remove that left ovary and fallopian tube. So I put my camera in and I see this. These cases, like, that ovary stuck to the left pelvic sidewall, and that it's always stuck right where the ureter is supposed to be sitting. So, you got to be very careful with that. I've been always taught when you have these cases to open up the left pelvic sidewall and do a ureterolysis and dissect out that ureter. But I found that, I guess, if you can dissect, and find that plane, most of the time you don't have to do that. So, I'm big on that hydrodissection thing. So I just hydrodissect the ovary and fallopian tube off the pelvic sidewall, and not try to interrupt or get into that retroperitoneal space. And I think the majority of the time I'm able to do so. So I don't know. That's and then if I need to take out a nodule of endometriosis, then I'll open up that space and dissect out that ureter and try to free it up from scar tissue. But yeah, for the most part, hydrodissection is good enough.
Alan, did you ever get, do you routinely get CA-125s on these?
The problem with, I don't, because CA-125 is going to be elevated in endometriomas, right?
Yeah.
So in those cases, I mean, like if I suspect an endometrioma, you get a CA-125, it's going to be elevated. What do you do?
Well, it's just, it's one of those catch-22s because you know that CA-125 is just a screening test. And with endometriosis, it is going to be elevated. But what if you did, let's just do a hypothetical. What if you did, I mean, you knew this girl had endometriosis because she had had a scope a couple months earlier. But what if you did get a CA-125 and it came back, 250? Then what would you do?
So patients that are young, they say young females with a complex, adnexal mass that you're suspecting cancer. I mean, it's CA-125, but you also have to order like the other tumor markers like LDH, AFP, HCG, inhibin A and B, and CA, all of the tumor markers for the germ cell tumors. And I think, I order those when I'm thinking when I'm suspecting that it's, there's a possibility that it could be a malignancy. And I don't know, I don't usually order an MRI, but I'll order those tumor markers and then kind of go from there. But if I have a complex cyst, what I do is I actually look at the evolution of the pain. Like if a patient has a complex cyst without much pelvic pain, that would make me more worrisome about a malignancy than a patient who has a long history of cyclic pain every month, and then it becomes more persistent, and then it worsens around the time of her cycle, but she always has low-grade pain. Those are the cases that like a history of pelvic pain and this complex mass. That's what I'm thinking. It's endo. What do you do?
Have you ever had a clear cell carcinoma?
I did. I had one in a patient with in a patient with what you call it? She was old, like an older female,
I had a 39-year-old patient that had a persistent left adnexal mass, and I did a left ovarian cystectomy on her, and it came back clear cell carcinoma. And the oncologist that I sent her to was kind of on my case for not doing ovarian tumor markers prior to, because basically I changed her staging from a 1A to a 1C.
Right, but even if you got
she still needs chemo regardless.
Yeah, I guess it was just, it's kind of territorial what the follow-up is for those patients and the morbidity associated with chemo versus what they're going to do. But anyway, ever since that happened to me, I've always started getting tumor markers.
So that OVA1, that OVA1 tumor marker, that I was ordering those for a while, and those are, that tumor marker, my understanding is you order it if you're suspecting that there's a complex mass that could be cancer, and then if it's elevated, you have a gyn-onc available, or you refer out. But clear cell doesn't elevate that tumor marker either. That's right. So I don't know. I think clear cell is a difficult one. My understanding is you order if you're suspecting that. So
you guys hear somebody singing?
I do. I'm trying to figure it out.
That's not. That's Dr. Gonzalez's house, I think.
Let's see if I can, let's see if I can read that guy.
Okay.
Hold on. We got a pretty good group tonight. Thanks, guys, for showing up. I actually don't know who that is. I'm going to mute everybody.
That's Dr. Gonzalez.
Anyways,
I know
Yeah,
with
so-
this work thing that I was supposed to be a part of. What's that game is? I don't want to. This is throwing you in a bed can't be the thing that.
oh, that's Nick. I muted you, Nick.
Hey guys.
You can unmute yourself if you want. All right, I'm going to mute everybody. But if you guys are want to say something, just unmute yourself and join in. Yeah. So, like as I was saying, this girl's got like this isn't like a crazy endo case. It's just an endo case. But I hydrodissect out the adhesions, try to mobilize that ovary as best I can before trying to take down the pedicles and remove it. But the hydrodissection thing works well for me. Like I haven't had any problems, and for the most part, it prevents me from getting into weird planes. And if the adhesions are very dense, what I found was that like if you squirt enough fluid at it, it'll break up the thin adhesions and then allow you to kind of bluntly dissect, and then you kind of keep moving on. But even the most dense adhesions I can take out with whoops, man. Technical difficulties, guys, sorry.
So in the can you hear me, Al?
I can.
So we all I'm sure the group agrees that the treatment is to do a cystectomy, right? Instead of just a needle aspiration.
Oh, right.
So I mean, that's been established for several years now. So I just wonder why somebody would just do a needle aspiration on that girl.
Yeah. Maybe it was because she was seen through the ER, and because of that, it wasn't like a planned surgery. Maybe the surgeon wasn't comfortable doing it, but I don't quite know. But it's disappointing because she came back with so much more pain.
Hey Alan, how are you?
Hey, what's up?
It's JD Eugenia from St. Louis.
Yeah, good to see you. Thanks for joining.
No problem. So just joining in with the whole cyst aspiration. So to be honest with you, because we're a referral center, like if the patient is actually has a big cyst and a generalist is just looking at it and they want to actually just take it or take the patient to the operating room to take a picture of it to document, and if they don't want to open the spaces, I 1000% prefer that they do not do a cystectomy. I'd rather they just aspirate the cyst and then send the patient to competent people that are going to be able to do proper excision surgery. Because the problem is that when they start getting into these things and just like drain it and then try to do a cystectomy, what happens the majority of the time is that they start doing oophorectomies on patients. And I am sick and tired of seeing 28-year-old girls with castrated because of bilateral endometriomas that never had kids. So yes, the treatment is cystectomy, but like not all GYN surgery is the same. Not everybody has the same level of skill, or not everybody has like done enough to be able to be competent enough to do a proper cystectomy and excise everything from the ureter. Or like take their time to separate the tissues, right? And then do things after the surgery to prevent scar tissue formation again. So yes, cystectomy is warranted, but it all depends on the skill of the surgeon. Those are just my 2 cents.
No, that makes sense. So my question is like, say you got a patient who keeps coming back with recurrent endo and, you know, an endometrioma that's returned. She's already had one scope. Like, how many times do you do a cystectomy before you decide to do that whole oophorectomy, you know? Like,
thank God at the moment I have not been put in the position to have to make that decision, because the way that I approach cystectomies is basically, obviously you want to take out the cyst, but we're very meticulous at making sure that we're removing as much healthy tissue around the cyst as possible.
right.
Keeping into consideration that, even a small piece of ovary that you leave behind is beneficial. Right. So, and
Right.
obviously, it depends on if the patient wants to get pregnant in the future or doesn't want to get pregnant in the future. But even if they want to have a hysterectomy, like, I am very, very much against surgical castration. Like,
Right.
that is a last resort type of thing that we should do, right? I always tell my patients a very, very simple joke. Like, what are the two reasons that men die more than women?
What?
Number one, we say stupid things like, dude, hold my beer. And two, right, we don't have ovaries.
Yeah.
That's very simple. Like, just cholesterol health is such important. The ovaries are such great regulators of our cholesterol. So why are we castrating and shortening the life of women, just doing oophorectomies left and right? Right? So I am very much against it. And I've had discussions with many people regarding the subject, but we should do what's absolute in our power to try to leave as much ovary as possible.
So, like,
healthy ovary.
In patients with very, very complex endo, right? Like, how often have you performed a BSO for treatment of endo? Because that's something that I see, like, younger women, less than 50, who's gotten BSOs for management of, chronic pelvic pain for endo. Like, I don't think I've ever done that. Like, I try to excise the endo and they've always gotten better, but some patients get BSOs and it's kind of surprising to me. Do you see that a lot?
Yeah. We have so many patients that, like, they get the wrong treatment for endometriosis. They go ahead or they try to do surgery. They take out the ovaries, they do a hysterectomy, but leave a lot of visible disease back in the pelvis. So then when the patient goes back to them, hey, my vagina is dry as a bone, like, I need some help, I'm going crazy, please help me. Then they put the patients back on estrogen. So that, to me, is bananas.
Right.
It's bananas how in America this thing is happening. Like, it's like, why are you removing the ovaries, right? Because you can't remove all the endo, or you don't feel comfortable removing the endo. So you basically castrate the patient in order to kind of diminish the amount of circulating estrogen and progesterone, thinking that those are the only two things that are going to drive the disease, right? But then when the patient comes back complaining to them, they put the patient back on estrogen.
Hey, so before we continue, why don't you tell everybody your background, like training and everything, and like your practice setup? Because I know that you do pure endo, right? Is that correct?
Yeah. We do 100% endo 24/7.
So what's your like training background, all that stuff, just so everybody knows?
Okay, so the short and sweet version is born and raised in the Caribbean, Dominican Republic, corn-fed. Did residency over there, then decided to come back to come to the U.S. So I basically went to med school again, took my boards, did my residency in New York, finished in 2007. Then I became an attending in the Boogie Down Bronx, Lincoln Hospital in the Bronx.
So I did.
I remember you back then.
Harlem. I was in Metropolitan Hospital in St. Vincent's for a year.
I lived really close to Metropolitan. I actually lived on First Ave.
Oh, I used to visit the White Castle there all the time.
I did that when I moved to America, and when I actually moved to the US, I went to White Castle one time. That's it.
I think I did too, and I got scared.
So sick after that one time, I could not do it again. I couldn't do it again. I couldn't do White Castle again. But so then after that, after residency, my residency was actually very heavy in open surgery and a lot and way heavy in OB. We used to go to Cornell and Southside hospitals to like do a lot of GYN, but it wasn't sufficient, right? So after that, that's where I actually met one of the guys that's here, Jeff Lynn, super cool guy when I met him back in.
Jeff.
Yeah.
Yo.
Dude. Yo, Jeff, how you doing, my brother?
How are you?
Hey.
Good. Jeff, actually, to be honest
Hey,
with you, I have to thank Jeff. He defended me 50 times from our chief while we were rotating. He took care of me. Jeff was amazing.
I'm trying, man.
Like after residency, I basically became an attending in Women and Infants in Brown in Rhode Island, a community faculty, and it was super cool. But after some time, I had so many patients that had endo, and we were doing the same stupid song and dance, birth control and do something else. And then, well, we can't do anything more for you, so go look for another provider or send them to oncology, which I felt that the oncologist should be not necessarily, I mean, most oncologists don't want to deal with endo. I'm happy that Jeff does, but most oncologists that I've met like do not want to spend their time dealing with endo patients. So after that, actually, I kind of saw the light and I decided to apply for fellowship after I was an attending for 4 years. So I did my fellowship at SIU in Springfield, Illinois, a big change of pace. They had some endo people there. And then I went to what I consider the Mecca, but obviously I am totally biased. And part of my fellowship, I actually, I did rotations with Dr. Sonerbo in Atlanta.
Right.
And then I actually, after the fellowship, I stayed with him longer, just learning endo and excising and using the laser, but basically identifying tissue, opening planes in a beautiful way. And it was totally different. I mean, and I can see the difference in his patients. Like I saw when I was in his clinic, patients that had like one surgery and done. Like had one surgery, kept their ovaries, no castration, removed all the endo, did bowel resection if was warranted, and then it was done. Like the quality of life, like years after surgery, like it was very different from what I had seen before. So then I was lucky enough that a past trainee of him was looking for people to work with him, Patrick Young, also in St. Louis. So I interviewed with Patrick.
So your fellowship was in Springfield, but then you did extra training in Atlanta, a different thing?
Yeah.
How different were those? How different was like the approaches? I mean,
like it was like night and day.
Right.
Like it was totally different. SIU was more like AJL. My AJL fellowship was more like, okay, cut some stuff out, open some spaces, and then put the patient on Lupron, and hope for the best, and then just but leave disease behind, right? And then that when I did my fellowship, that was like an insult to right. No, we're gonna leave, or we're gonna go after that. I'm like, yeah, we're gonna go after everything. We're gonna go ahead and remove all the disease that we see from wherever it is, diaphragm, livers, like, and everywhere. So that was like, okay, this is how you're supposed to do this. So it changed my approach.
Yeah.
And now actually, I'm in St. Louis, and it's pure endo, which is a blessing actually, because I'm writing Young's coattail, because since the moment I started, I'm basically doing anywhere between 25 to 30 surgeries a month of just purely endo.
And these are like the worst endos ever, right? Like multiple.
Well, we're a referral center, so it's easy for us. There's some patients that are really bad, and the good thing is that we're doing a lot more surgery on teenagers.
Oh, good. Yeah.
And I'm happy about that. We're doing so much surgery on teenagers, and we're finding endo on teenagers.
Yeah.
Like our rate of finding endo once we screen the patients properly is close to 82% on first surgery.
Wow.
So we must be doing something decently.
So I have a question for you. So, you got patients who's got like, adenomyosis and endo and, big endometriomas and, patients that have like endometriosis in all of these crazy places. Like, sometimes I'm not 100% like excise all the endo, like I'll do the surgery where I'll do the hysterectomy and address the endo, like, but how much is it always for you, like excise everything, or like, like if I had a patient who had like endometriosis on the diaphragm and, majority of her pain is in the pelvis, like I would focus on the pelvis and not go crazy. I wouldn't even touch the diaphragm endo because that would scare me. I mean, people have experience with it, but is that something that we should all be considering? Like if you see endo and
Yes.
it's not an area that,
Yeah.
that it seems like,
Because the problem is that it's not an issue today, right?
okay,
Today is not going to be an issue for her. So today is where we have to address it. Because when it becomes a problem and then she's having, catamenial pneumothoraces, then okay, oh well, fine, we're going to address it now. But then it's way more. I mean, there's a lot more morbidity to the patient when we're addressing something when there's disease on it. That's why we're very, very aggressive. Like if we see some stuff on the bowel, on like some lesions on the bowel on stage 1 and 2 and some nodules, we're gonna shave it. And if we have to put a couple of stitches through the bowel, we stitch it. Now, a question that I want to ask actually the group, like, I bowel prep 100% of my patients, but I do it because what I'm doing is I'm using a laser, which I need the bowel to be flat, right? If I'm putting a manipulator through it, it's better. If we have to make a hole in the intestine, just like cut that piece and suture it and secure it. And that, I mean, what is your take? Have you considered doing bowel preps for patients with stage 4 endo all the time?
I don't do bowel preps on anybody. And the reason is, so like, I did 2 years of general surgery beforehand, so I'm familiar with the bowel preps they used to use. And, then they started saying that, bowel preps aren't advantageous. And if you do like bowel reanastomosis or bowel surgery, from what I remember, bowel preps can increase the risk of anastomosis leaks. So like when I, left general surgery, that was the trend, like not doing bowel preps in patients with, you're planning on doing surgery on. And I've never noticed the difference in, hold on a second. I've never noticed the difference in anybody who, didn't have a bowel prep. Like I never had an issue with like a colon full of stool. And the other thing that I didn't like was the fact that when I do, you do bowel preps, like their food balance status is so off. Like they're negative, and I don't know if they're dry or not, and I don't know, kind of made them miserable. So, that's kind of why I stopped doing them, and I haven't ever had any problems with it. But then again, I don't enter into bowel and do bowel resections and stuff. So, and I don't plan on doing.
Hey, Alan, can I say something?
Sure.
Yeah, it's Nick Fogelson. I those that don't know me, I do a lot.
I was actually really hoping that Nick would say something.
Thank you, Nick.
I mean,
Thank
so
you for coming.
let's talk about this surgery that's happening in front of us here. Is this your surgery, Alan?
That's mine, Nick. Take it easy.
Well, you're not really doing endometriosis surgery is the problem. I mean, all this stuff that you're pawing around on with your suction is endometriosis.
Okay.
So I don't really understand what's going on here.
She had a big dilated tube full of like, old blood. And
I know, but like what we're talking about when you're asking about do we excise endometriosis, like all of that density of her uterosacral ligament is deep infiltrating endometriosis. So I would handle that surgery totally differently. Like whether or not the ovary is going to come out, if it is, it is. But I would be, and I think, Jose would be the same, like get way retroperitoneal, expose the ureter, bare the ureter. The first thing you would do is completely unroof over the ureter. And that whole sidewall's got to go. And the whole uterosacral ligament and posterior vagina is all endometriosis. Like all that's got to go. Now, I mean, it's fine if what we're talking about is how do you take out an ovary, but if you really want to talk about how do you excise endometriosis, you got to approach it differently.
Yeah, no, this is why we're posting this, so we can all learn from it. So like,
and this right uterosacral ligament's got disease in it too. It's not as bad as the left.
Yeah, no. So tell me, like, tell me more. Like, what?
Well, I think that first of all, I think the thing about an endometrioma that you really have to consider is that the problem is not just the endometrioma. The problem is the endometriosis that is in the sidewall underneath it, because the reason why she has pain is that it's all that's getting inflamed every month, and it's going to her first, second sacral nerve roots are running right underneath that big mat of tissue. And so every time that gets inflamed, she's going to have pain into her pelvic floor. She's going to have pain down her leg because it's going to inflame her sciatic nerve. So really, and the depth of that disease is sort of indeterminate at this time, but I'm sure it's a good half a centimeter thick of stuff. And by the time you really remove that entire sidewall, you find that that's a big chunk of tissue there. This right side, not quite as bad, but right as the uterosacral ligament comes into the cervix, that's a lot of endo, to be honest. I mean, it's a nice chunk of tissue that is going to come back path positive. So I would just approach it a little differently in that, really, what do you think, Jose? I mean, it really, and Abhishek too, a lot of these kind of cases.
So you are correct. Like, I would basically just go back to the pelvic brim, grow from healthy to unhealthy, and just open the whole ureter all the way down until it's under the urinary artery, and then start dissecting tissue, making sure that hopefully you're not removing both inferior hypogastric nerves and being really gentle with all the tissue that there. But everything that's fibrotic, absolutely everything has to go.
Okay.
And again, I mean, obviously, and you can see, actually, let me ask you a quick question. Like, what manipulator are you using right there?
The V-Care.
The V-Care. Okay.
Yeah.
Do you use rectal probes?
I haven't. I mean, I have in the past, but not honestly. Like, I haven't used one for a long time. But yeah, I haven't in a long time, but I've used them before.
So I would definitely recommend. I mean, you should definitely consider using a rectal probe so that you can basically kind of push in, open up that.
In this case,
in every case.
Really? Tell me why.
I use a rectal probe in. Well, I mean, I do a lot more stage 4s and that, obviously, but even for small, because you want to also like. There's a good video that God, I'm blocking his name right now. He's gonna kill me. There's a good video that this guy that he's also at the CEC, he put the other day. I'm blocking his name. He's gonna murder me. But he put a video, and like, when you can see, actually, when you put a rectal probe through the rectum, you can see the indurations on the bowel. You can see all that stuff, and it's really, really helpful also to drop down the bowel whenever you want to remove all that retroperitoneal space, which is really what you have to do in order to shave all that tissue from those uterosacrals.
So this is interesting. So, like, I thought that the value of a rectal probe is, when your posterior cul-de-sac is obliterated and you're worried about, you got to get into that perirectal space. But what you're saying is put a rectal probe in this case, because I'm going to be dissecting into that perirectal space anyways to remove that endo that's in this case.
So you should be opening that the space right behind the cervix, everything medial to your uterosacrals and lateral to the uterosacrals. So the rectal probe helps you basically mobilizing the bowel to the contralateral site that you're working on. Because right now you're actually fighting the bowel.
Right. Who did that? That's awesome. You circled that, JD?
No, it wasn't me.
That's me.
Oh, nice. Thank you. All right. So that's the part that needs to be excised, that little area. Or, I mean, that whole side area.
Yeah.
Really?
Okay.
Hey, Alan, everyone, it's Marty. Can you guys hear me?
Yeah,
hey, Marty.
Hey, everyone. Congratulations on getting this together.
Yeah, thanks.
I think it's great. I just was going to ask, how old is this girl again, this woman?
So this girl's 37. She had a surgery 2 months prior. She was in the ER, chronic, like just constant pain. It's not even cyclic anymore. I mean, she's just always in pain, and she was miserable. The first surgeon took her to the OR, and the op report said she aspirated a cyst, and I think it even said did a cystectomy and excised endometriosis. But 2 months later, she was back in the ER, and I took her to surgery, and this is what she had. She had a.
Did she want more children or no?
She's not in a relationship. I asked her if she wanted to keep that ovary, but she said she's tired of the pain and she just wants, it removed. So
No, I was just thinking of the uterus of doing the hysterectomy.
Oh no, she's definitely waiting for somebody, but she doesn't have them yet. So
got it. And just to touch on the bowel prep, guys, in GYN oncology, we've moved away nearly 99% from bowel preps, and even for our ovarian cancer cases, when we're doing bowel surgery, robotic resections, we found that having formed stool is better than having diarrhea and loose stool when you're doing the surgery. So for that reason, if you get an enterotomy or you deliver it or not, if you have taken a bowel prep, you're likely going to have a spillage. But if you have formed stool, it's not going to move. So we found it easier for suturing and better for in our experience. So we've gone away from bowel preps. I don't do it anymore. And I'd say that's, the majority based on, the Mayo Clinic ERAS papers 3, 4, 5 years ago, most people probably have shifted away in the ovarian cancer debulking when we're actually doing bowel surgery.
Okay.
Nick, do you do bowel preps?
Yeah. Am I still muted?
Yeah. No.
Yeah. So I usually do. I mean, I do a lot of, disc resections and shave procedures that sometimes enter the bowel. And I guess I just like it when you can make a hole and there's not poop coming out of it. But I mean, obviously there's no science behind it. Sometimes what I do is just do like an enema with some Dakin solution right before the surgery starts. After she's asleep, I put a 30 cc Foley in the rectum and take a whole bottle of Dakin solution and in about 30, 60 cc doses, just shoot it up the bottom and then have it come out. And then that kind of cleans the last foot of the bowel more or less. And that's all you really care about. I mean, I don't care about the small bowel or anything more than, anything that's about 15 centimeters from the anus, I don't really care about either. So that works pretty well.
JD, what is your bowel prep?
Like we showed a video. Maybe I could show a video sometime of how, an excisionist would handle this kind of case, because this is a pretty common kind of case. And that ultimately, like when this case is over, if I did it, there would hardly be any peritoneum left in the pelvis. Like almost all the left side will be gone, all the right side would be gone, all the area behind the cervix would be gone, and you would have the ureter bare before God, and the uterus, the hypogastric nerves would probably be exposed pretty well too. So it's just a completely different approach. Like this is how to perform a oophorectomy, but it's not really endometriosis surgery in my mind. I don't mean that as a criticism, but it's like if you were to say, okay, how do you deal with endometriosis? I would say, well, that's not really it.
Okay. That's fair. Like, this is why we're meeting, because there is no standard, this is how it should be done. Like, I want to hear from you guys, like the endo experts, how it should be done, so I can get closer to that than doing something inadequate. You know what I mean? Like,
well, one of the things, Alan, I think it's really kind of a shame, and we could all kind of address it, is that when you go to AAGL, you mostly see the most difficult endosurgeries in the universe. And if you don't already, if you're not at the level to absorb that and replicate it, it's hard to get from step one of being a really good minimally invasive surgeon, but not really doing a lot of endo to that. And there's not enough video out there of sort of a case like this, like how do you do this? There's a lot of video of like how to do colon resections and stuff. So it would be nice if we could maybe have another one where maybe me and Jose and some other people could show some stuff like this. Cause I mean, I probably have 30 videos of something like this that no one's ever bothered to publish.
Yeah. Like a case where it's not the craziest thing. It's the cases that generalists would see, but how you guys would manage it. Cause
that's totally fine. We could definitely do that. Like, I record all my surgeries. So I literally have
so do I.
All the surgeries and I keep all the surgeries for at least 5 to 10 years. That's my kind of goal. Right now I'm at 5 years. But that would be the
I mean, if you have one, let's share, let's put it up right now. If you guys have
I don't here, I have it at my office.
I'm actually at a I'm supposed to be at a dinner. So my wife already came in and say, "Are you really working right now?" I was like, "Just I love you, and just let me do this and we'll."
No, that's That's you're funny. My wife is pissed off too, but I figure it's worth hanging out. You know,
Out the small piece if you want to eat, and the big one is a 140.
oh, hold on. I'm trying to put this video back up.
All right. Yeah, I ate a little bit off of that, and I'm okay for now. I've been sick all
Hang on,
day.
guys.
So, yeah, I'll So did you take the other one out? I took the little piece out.
All right. Sorry, guys. Trying to put another video on it. Things are shutting down. Hey,
Alan, this is,
yeah.
Abhishek Nageshika. I asked a question earlier about the criteria for scoping a teenager because you can't do ultrasound imaging for non-sexually active teenagers, and the MRI may also not be able to pick up all the endo. So do you do a transrectal scan, or just based on her clinical history and non-response to I don't know, maybe failed traditional pain management?
I'm sorry, tell me again.
So
for adolescent endometriosis, what is the criteria that Dr. JD was using for, if he's still around, to...
Yeah, I'm around.
Oh, hi. To scope the adolescent population within negative imaging?
So, well, imaging is not going to, it's more symptomatology and more failed months and years of birth control and switching and doing this and doing that. But I mean, the data is there. Like if they have, well, if they're not sexually active, but let's say that they're sexually active. I mean, obviously it's not the same because most teenagers that are just starting to do sex are going to have some type of deep dyspareunia. But the switch with diarrhea with their periods, that the severe pain, it's way more, it's hard to describe, but it's worse. It's like all their symptoms are way worse. And then we do find endo a lot of times. And the thing is that the good thing is that you find a couple of spots of endo, right? You're not finding massive endo. You're not finding stage 4 endo on teenagers. But you find some lesions on the uterus sacral, some lesions under the ovary, some lesions close to the hypergastrics that kind of explain that sometimes some of this, obviously, the association with the IC. And these patients do get better, but you've seen patients that have been suppressed for months, and they have severe pain. So, I also see a benefit in actually finding out if they have endo or not at a young age. Because like something that I heard somebody say at the last Endo Summit was very powerful to me. Like endo speaks as teenagers. Like teenagers are complaining for this for months, and they say, well, nobody listens to me. And then my mom tells me like, oh, all the women in my family were like that. It's fine. But all the same thing happens, that all these women that in their families that had endo or had really bad periods, they got pregnant multiple times at a younger age. Yeah, right. So it behooves us, like family history. There's a lot of different things, that clues that you can find in talking to the patient and figuring out if they're not sexually active. But obviously, like MRIs and these things are not going to be beneficial. You can do a transrectal sonogram. You can try to see if it's possible to do a transvaginal sonogram if they're old enough and they've been sexually active before, or you can do a transabdominal sonogram. But in all honesty, you most likely not going to find a lot of imaging that are going to show you significant disease on teenagers.
Yeah, I agree.
At the end of the day, what is the imaging for, right? Is it to help you make a decision to surgery or to make a decision away from surgery? I think you kind of have to answer that first. And a lot of times for endometriosis, the ultrasound, even MRI, is not really going to be the one thing that's going to push you to it. It's really going to be her symptoms and her history.
Yeah. You're correct, Jeff. So sonograms are basically kind of like help you confirm or kind of help you also guide surgery. Like the way that, for example, when we have patients that we have high suspicion of bowel endometriosis, we do a sonogram with a rectal prep. Like we have the patients get an enema an hour before the sonogram. We take Dulcolax the day before, but also because we want to make sure that that rectum is totally clean. And you can see beautiful beautifully. You can see all the nodules in the uterosacrals. You can see them right on top of the on the bowel, right? So you can see these things, but obviously it takes a very, very highly skilled sonographer and years of or months. For example, one of the things that we do is since we give patients pictures, we also take these pictures, like all these pictures get scanned. And then we sit down with the sonographer and say, okay, what you found that it was this is how it looks. Because if the sonographers can understand what they're looking at, instead of most sonographers are going to go, okay, so this is the ovary, this is the size, this is a cyst, and move on. But to have a sonogram in which you can actually see movement and then see the relationship, making sure that the bowel is sliding behind the cervix, right? And it's not fixed. These things are very, very helpful. And a lot of the times, if the patient has, you can actually also put water in the cul-de-sac, right? Yeah. So all these things help, like separate things, and it's really, really good.
Sure. So is this, are you reading your own ultrasounds, or do you have an ultrasound?
Yeah, I do my own, and I also read my own MRIs.
What about you, JD?
So we have a sonographer that does it for us, but I read the images myself. And we are actually working on the MRI. We're having some issues. We wanted to basically kind of like establish a protocol for the MRI so that the way that they're actually describing the MRI is focused to what we want.
Yeah.
Right now, they usually kind of just comment on, okay, this is an endometrioma on this side, and that's it. But they don't necessarily go into the cervix or the space behind the cervix or the nodules, or like they don't go deep into those things, and that's something that we need. But
Alan,
again, that's more to
in your
help to
office?
plan for surgery.
Right. What's your question, Marty? Was that you?
Do you have an ultrasound in your office?
No, I don't. I send them to radiology.
Yeah, I will tell you that I think that that's something as the gynecology community, we all start to do more of these, that it's something for us to think about becoming proficient in. Especially, in the Kentucky data recently was screening ovarian cysts, and looks like there may be, some good signals for prevention at some point, doing annual screens for women at 50 and over. So it's something that's just starting to pick up some press, but they've got a free program in the state of Kentucky for any female to get a screen 50 and over.
That is great.
So are these ultrasounds that get official reads, or is it just like you do an ultrasound?
Well, in Kentucky, it looks like the Kroger supermarket is paying for these. So it's been a 30-year prospective pilot study that they've done, and they've shown now you can reduce mortality, but it hasn't not become standard of care yet. So that's going to take time. But I think from GYN, for all of us, will be to our benefit to start to become proficient in 2D and 3D ultrasounds, because I'm hoping in our lifetime we'll make, use that tool that we've all seen and used in OB and bring it to GYN in our office to really, see where we can try and not only prevent cancer, but also help these women with endo and uterine reconstruction and all that.
Nice. So how do you guys manage your patients after surgery? I mean, like after your endometriosis surgery, is that all you guys, is it done and they're cured and nothing else? Is that the end of it?
No, they're not cured. I mean, that's unrealistic. That I think this kind of funny concept of what cure means, right? So some, like David Redwine would say, well, if you go back and rescope them and you can't find endometriosis, then they're cured. But I don't find that to be a very useful distinction, because there are plenty of people that have really good excision surgery that still have recurrent pain, and we don't really know why. It could be the fibrosis from the surgery. Like sometimes you go and you can see the fibrosis from what was done before, and it's not endometriosis, but they may still have some nerve compression. But also people have interstitial cystitis. They can have pelvic floor issues for sure. I mean, so, I think most patients should work with pelvic floor PT. A lot of patients have an element of adenomyosis, and so being on hormonal suppression can be reasonable for that. There was studies that looked at suppression versus no suppression after surgery, and the suppression group has a lower incidence of recurrent pain. And some of the excisionists will argue, says, well, that study is done with ablational surgery and incomplete surgery, and that's why they got that result. But nonetheless, that's the best data we have. Like, we don't have a study with, really thorough excision surgery reliably being done and then looking at suppression or not. Like, that study doesn't exist. So the study that does exist says that suppression is helpful. So I think that's the reasonable thing to discuss with patients. And if they're not trying to get pregnant, then I think it's reasonable to do that.
Okay. JD, what do you do? Same thing? Oh, I think JD went to dinner. Jeff, what do you use after surgery?
After surgery, usually I ask have the patients go back to their primary OBGYNs, but I do send them on OCPs.
Do you have like a particular OCP that you like more than others?
Not particularly. I usually just say Sprintec. Not actually super familiar with the, nitty gritties. I don't know if you guys have what's everybody's specialty.
I think you really want to. I mean, theoretically, not based on any data. I think you want one of the older progestins that's more progestational, because as birth control pills have kind of evolved, we've gotten less and less progestational and more anti-mineralic corticoids. So like the most modern progesterones like drospirenone really are anti-mineralic corticoid and not very progestational. So they're not going to suppress endo very well. So if you go back to something like loestrin, which is a second generation progestin, that's going to have a much stronger suppressive effect on endometriosis than one of the much more modern ones. And Sprintec, which you mentioned, is a third generation progesterone. So that's going to be probably not quite as good as norethindrone and better than there's two fourth generation progestins, which are, theoretically not as good. But of course, this is all like conjecture based on physiology, but no data to support.
Nice.
Do you guys ever do the patch?
I don't use the patch.
They get very high estrogen levels on the patch. That's one thing. Is there was data on the patch showing that the peak estrogen levels are very high. Probably.
I agree. I don't like the patch, and I absolutely hate the NuvaRing.
Yeah, I think the patch has like a much higher risk of blood clots too. That's why I never use the patch though.
Yeah, because of the very high estrogen levels. I think that's true.
Personally, I if I'm recommending something after surgery, I'm kind of telling them either the Nexplanon or Micronor.
Yeah.
That's it. I stay away from any type of estrogen, like giving them estrogen after surgery.
Micronor is
personal choice.
norethindrone?
Yep.
Oh,
if I'm going to suppress someone with norethindrone, like they're in pain, they don't want to have for suppression after surgery, whatever, Micronor is fine. But if you're going to say that someone has recurrent pain or they have endo pain and you're not going to operate, I'm going to use 5 milligrams or 10 milligrams of norethindrone.
Hey, Justin. Yeah.
0.35. I mean, Micronor is 0.35 of norethindrone acetate, whereas Agestin is 5 milligrams of norethindrone.
5 milligrams, yeah.
So it's more than 10 times as much, or 20 times as much if you 10 milligrams. So, it's 30. So you can get more impact with more progestins if that's what you're going for. But you'll get more fluid.
Yeah. Also, true. Quick question for the group: like, do you guys do anything before surgery? My recommendation for patients is nothing, no suppression, no Orilissa, no Lupron before surgery, at least 30 to 60 days before surgery, because the point of some of these things, if they truly suppress the endometriosis, I don't want that. I want that to be very live and well and kicking at the time of surgery, because I want to be able to make sure that I'm not missing. I mean, to me, in all honesty, what is the point of taking a patient to the operating room while you're suppressing them with Lupron and Orilissa? Like, one of the hardest cases that I've done in stage 4 in patients that have been suppressed on Orilissa by another provider, and they don't want to give it up before surgery. Everything, it's just worse. It's like trying to do a myomectomy. Myomectomies in patients that have had uterine embolizations or Lupron for a long time.
Yeah. No. What about like Depo? You guys use Depo after surgery?
Provera or Lupron?
Yeah. All right. Anything else you guys want to bring up?
There's something that was said earlier, like we talked about, like when you're treating a patient for endometriosis, like I think you said something about the doctor before treated it and it came back. So that's something that we have to be, when we're talking to patients, we have to be honest with them, right? So you shouldn't tell that patient, oh, the doctor that treated you before like did the surgery and then it came back. The proper thing to tell the patient is that it never went away.
Right, absolutely. No,
right, because what happens is patients then it never went away. And so it's not like, because you saw it when you, like, it's impossible. Like I've seen, and I mean, it's really, patients in endo, they're a different type of people. They do their research, they go back and they look. And then, for example, like one of the things that keeps me up at night is that I do surgery on somebody, and then they look at the op report and it says something completely different from what I tell the patient. Right? You cannot imagine how many times I give patients a copy of everything: op report, pictures, pathology. So it's like creating a folder for this actual event, so that if we ever have to go back, we can look at the last picture, and I take pictures of everything before and after, because patients are it's sad to say this, right? But patients are lied to. They tell them, no, it's okay, you don't have anything, or I did surgery and I burned the surface and I took care of everything. And then we go back a couple of months later and patient needs a bowel resection, has endo in the diaphragm, endo in the appendix, like everything is a mess. So, I mean, this only happens in endo. And some patients are going to start to smarten up. And I fear the day that patients start, the litigation in this department gets as bad as the litigation in OB.
It's difficult because not everybody really knows what they're doing. I mean, and I don't mean they don't know what they're operating, but they don't, if you don't recognize the disease as thoroughly as other people might, then you may not know what you're missing. I mean, I had a case where a patient was scoped and she was reported to not have any disease. And yet on exam, I could feel the mass between her rectum and on her vagina. And she showed me the picture from the surgery that the previous surgeon claimed was demonstrative that she had no disease. And I immediately looked at it and I said, well, you have disease all the way through the anterior wall of your rectum into your uterosacral ligament. It's probably involving your like hypogastric nerves, like bad lesion. And I went in there and ended up doing a segmental bowel resection, a bunch of other stuff. So, you know, the previous surgeon wasn't lying. They just didn't know any better.
Right.
So,
I mean, I find that hard to believe. That's me personally. I mean, as a generalist, I mean, I was a journalist for 4 years, and it was not difficult to know, okay, there's endo here, and the cul-de-sac is obliterated, and this is stuck to this. And even though the surface looks very pretty and nice and pink, like there is the devil down there, which is why I'm not going to go and open it, right? So it's like
subtle. It was a really low lesion, and it had a kind of, like you could see, this is like red wine had described, sort of this bulging sign where if the rectum kind of bulges up into the back of the cervix, then that's usually very invasive into the bowel. Whereas if it's kind of tethered to the cervix, it's usually more superficially involved, where you see kind of a peak where the rectum kind of peaks up into the cervix. Usually that's the peritoneum of the cul-de-sac, and when you get in there, it's relatively superficially involving the bowel. But if it looks like it kind of bulges up like a ball, usually the entire rectum is just invaded. And this was kind of like that, where like if you didn't quite understand, you might have said, oh, it looks normal. But I mean, it's amazing is that some people you examine someone and they have a rock hard, extremely painful nodule at the top of their vagina, and somebody has examined them and said they didn't notice that. And it's like, I don't know how you don't notice it, but you know, if you just, people either not paying attention or just haven't really seen enough of it to know what they're feeling, and they just, you know, they just don't recognize it, unfortunately.
Yeah, no, that makes sense.
Or the contrary is true. You're doing a 3 centimeter vaginal exam.
Huh.
I mean, I'm actually, to be honest, I'm different at the moment because I'm very jaded about all this crap that we see. So it's hard not to be annoyed and pissed all the time. And because of this, right? Because, I mean, we're basically playing with people's lives, right? And I don't see the support from other institutions like the people that are supposed to be, the patients are not supposed to be advocating for themselves. To me, that is bananas, right? We are supposed to be basically doing better. We're supposed to advocate for our patients. And I tell generalists all the time, it's okay not to know. What is not okay is like tell the patient that she doesn't have anything in it and that it's going to go away and it's all in her head, right?
Right.
And then delay the diagnosis. Like it's okay to not know. It's okay to not know, but what it's not okay is to just cross your arms and say, okay, she's just crazy, and then kick her out of the practice, which happens a lot. Oh, fine. I'm going to send you to this doctor, and you don't have to come back over here anymore. So kick her out of the practice because you don't know what to do about her endo. That is wrong.
Right. And then the patients, a lot of them get labeled as just, fibromyalgia, you know what I mean? Or just sensitive to pain. That's something that I see all the time also. It's crazy.
Worse, they're pain medicine seekers.
Yeah.
Well, and the other difficulty we face is that, JD and myself and a lot of people would advocate, doing very thorough excision, but there's no financial motivation to do it within most people's practices because it takes so long and they're not going to pay you very well to do it. And so there's sort of a double-edged sword. Like we want people to get more thorough excision, but unless they're practicing in an environment where their employer is willing to kind of supplement their income with some sort of undisclosed kickback of facility fees or something like that, or you go out of network, like there's not a way to create.
You are correct. You're correct.
There got to be like a practice like yours, JD. Hopefully your employer recognizes that you're bringing them millions of dollars a year in facility fees, because you certainly aren't bringing them, a huge amount of professional.
No, they're not. Obviously, because they see RVUs and what they pay, and sometimes that I'm doing.
But it's not like there are people that have. You can play with that if you want to. Like that's what they want you to believe. But the reality is that you're bringing them huge facility fees, and they have to.
I imagine so. I mean, if I'm doing 25 to 30 cases a month of pure endo, that's right. Me and 30, and the same for Patrick. So they should 60 cases that we're doing. Between 50 and 60 cases a month of pure endo. And obviously, when we do at least one stage 4 with bowel resection case a week, at least one.
Well, it's like my practice too. And the facility fee for a stage 4 case is like $60,000-$70,000. By the time you do a colectomy and a 3-day hospital stay and a 8-hour, 6 hours of robot, 30, 40, 50, maybe more $1,000. And the professional fee might be $1,500 or something if you're billing Blue Cross Blue Shield or worse, Medicaid.
Yeah, we're lucky. We're very lucky. We do see Medicare and Medicaid patients. And we treat them equally, like they have the most expensive and best insurance in the world, obviously. But nonetheless, like we're lucky because we're a big group and they can kind of like support us, and they see the volume that we do and we're creating value for the residents, right? Even though I'm actually pretty mad at the residents and I'm trying to yell at them to see if any of them would do endo. And I get especially annoyed when they say, no, your patients are pain seekers. I'm like, don't say that. That's not the case. That's not the case. Or they're extra, or they're after surgery. They're too extra.
That I taught for 2 years. I literally had an AHL fellow that sat across from me for 2 years, smiling and nodding as I taught her how to do great excision surgery, and she learned how to do it. And as soon as she left, she joined Kaiser and decided that she didn't believe in endometriosis anymore, and she doesn't, if she ever did. And she tells people that you should just get a hysterectomy and go on wait time. And I'm like, what was I doing for 2 years teaching you this? It's like a waste of my life. It's very irritating.
No, it's not. It's don't you cannot view that. I mean, at some point in her mind, she sees it like, and she knows like I'm doing this. But yeah, you're right. Endo doesn't pay. It does not, and
Kaiser does not, like as a policy, Kaiser pretty much doesn't seem to want their doctors to do endosurgery, and I don't know of any people that work for Kaiser that really do significant endosurgery, except for Mallory Stuparich, but she left to join Matt Seedoff, I think.
Okay.
Well, that's a great. Guys, thank you so much for hanging out and sharing your knowledge with us. Very much appreciate it. Oh, by the way, this patient, she actually did have better outcome. Her pain was better after surgery. So
I'm sure it was for sure when people have endometriomas and you remove the endometriomas, there's an element of the pain that's much, much better. But I bet she still has dyspareunia. Like if you feel at the top of the vagina, there's going to be some indurated area up there that probably hurts to pain.
We'll see. I'll keep you guys updated. Thank you guys. Thank you everybody for joining us and sharing your knowledge and being part of this. Very helpful to all of us. And JD and Nick, thank you guys so much for sharing what you know with us. And Jeff, you too. Thank you guys. It's really helpful to learn, and I appreciate everybody.
Okay, guys. Have a good rest of your night.
Yeah,
I'm late.
Thanks, guys. Thanks for coming. I'll figure out what the next meeting will be about. If you guys want, send me some suggestions and we'll do it. All right. Have a good night, everybody. Thank you.